Hi, thank you so much for joining us today. It is our great pleasure to talk with you about implementing Senate Bill 1237 and integrating nurse midwives into California's healthcare system. My name is Paris Malouf-Burry, and I am the current president of the California Nurse Midwives Association. And it is my great pleasure to be joined today by Kathleen Belzer. Kathleen, why don't you go ahead and introduce yourself?
Hello, my name is Kathleen Belzer. I am the immediate past president of California Nurse Midwives Association and was very instrumental in passing SB 1237. I also want to give a shout out to Holly Smith, who is our health policy chair and is not with us today, but she also put a lot of work into this presentation and was very instrumental in this bill as well.
All right, let's get started. So I've included this image from the show Call the Midwife. Many of you have probably seen it and enjoy it as much as I do. And you've probably observed that the midwives on the show are not exactly hippie renegades. They work as part of an integrated health system, which is set up for success and role clarity. For perspective, the National Health Service has over 25,000 midwives integrated into a geographic region that is roughly the size of Idaho. But on this side of the pond, where we're just getting started, our objectives will start out with defining what is a certified nurse midwife, describing the current state of maternity care here in California, outlining what SB 1237 does and what compliance means, and then exploring steps that hospitals can take to implement the law, as well as what you might want to consider when you're better integrating midwives and what we have to offer. So let's get started. So what is a certified nurse midwife? Certified nurse midwives, or CNMs, are registered nurses who have completed either a master's or doctoral degree with a focus on midwifery and have performed hundreds to thousands of additional clinical hours, both managing primary care patients and attending births during their training. After completing their education, they sit for a national certification exam, are entitled to apply for a furnishing license and a DEA license from the state, and are able to independently prescribe, diagnose, and treat patients within their area of expertise, including independently managing the birth of a baby. This includes maternity care, interconception care, family planning, and newborn care. Like all healthcare providers, the certified nurse midwife performs patient care within their designated scope of practice, which includes preventive measures in the detection of abnormal conditions in mother and child, procurement of physician assistance and consultation when indicated, and execution of emergency care until physician assistance can be obtained when necessary. In the team-based approach, nurse midwives can co-manage moderate risk clients in consultation with a physician. In this model of care, the physician attends to the medical needs of the client, while the nurse midwife attends to the birth. It is through this approach that every patient, especially those with diverse needs, gets the right care at the right time by a diverse group of providers. We currently have over 1,100 certified nurse midwives in California. We attend 10.4% of all vaginal births in the state, with 95% of those births occurring in the hospital setting. This number is likely underreported, but that is a topic for a different presentation. Moving on to the next slide, let's explore the workforce here in California. As you can see, California has a maternity care provider shortage, which is compounded by an uneven distribution of providers throughout the state. There are 2.44 OBGYNs per 10,000 women and 4.69 per 10,000 women ages 15 through 45. The national average is 2.65 and 5.42 respectively. California's female population is expected to increase by 22.61% by the year 2030. 9 of California's 58 counties do not have any OBGYNs. With the passage of SB 1237 and the untethering of nurse midwives to where physicians already practice, nurse midwives are poised and ready to answer the call to fill the gaps in these maternity care deserts. 48% of California's births are financed by Medicaid. That's 45% nationally. And moving on, we see a similar trend with more recent data from 2018. A recent report by the March of Dimes shows 5 counties classified as maternity care deserts and at least 10 counties with very limited access. The March of Dimes classification of maternity deserts is based on both available providers and the proportion of women with health insurance. The impact, while less than 1% of infants were born in maternity deserts, and 2% were born in level 1 or level 2 limited access areas, this ultimately affected 15,000 infants born there, and many more women, approximately 400,000, live in level 2 access areas alone. Those maternity care deserts also represent VBAC deserts, places where women don't routinely have access to vaginal birth after cesarean. The March of Dimes has their own well-researched position statement on midwifery care and birth outcomes and calls for nurse midwives to be better utilized in these areas in order to improve outcomes and access and to amend state laws that restrict access, which is precisely what SB 1237 did. We can see the California Healthcare Foundation's report from 2019, which outlines the distribution of nurse midwives throughout the state. Recognition of this maternity care workforce was a driving factor in our push for SB 1237. And the video on the next slide explains this far more eloquently than I can.
Nurse midwives provide critical healthcare services in hospitals, clinics, birth centers, and homes, and present a solution to the crisis in U.S. maternal healthcare outcomes. They have been shown to create better outcomes for mother and child, while at the same time reducing overall healthcare costs. However, midwives in California face obstacles to providing care, and we want that to change.
The word midwife means with woman. A certified nurse midwife is an advanced practice registered nurse who goes through at least a master's level of education.
We take care of people through their pregnancy and their birth and their postpartum time. I think people think of midwives as really only being people that attend for births, but we really take care of the person and their whole family through that process.
Support on all levels, like on the emotional, spiritual, physical levels.
Gynecological care, birth control, abortion, pregnancy, postpartum, well woman care, all of that, and works independently as the medical provider.
That was kind of the epitome of midwifery approach and training, is to see the patient really in the context of their life, their family, their social situation. They bring that to the table in a much more broader way than I was trained as a physician, certainly.
Our high rate of interventions is associated with and in part responsible for our high morbidity and mortality rate in this country. Despite spending more money per capita on healthcare than any other country in the world, we have the highest morbidity and mortality rates of all of the developed world.
Midwives and midwifery care actually improves outcomes for birthing people. So you have a lower risk of having a major abdominal surgery or C-section by having midwifery care. And overall, interventions are used intentionally and with indication as opposed to routinely. And the impact of that is significant.
A 2018 study found that increased access to midwifery care is correlated with improved outcomes for families in the form of increased breastfeeding, reduced interventions, increased vaginal birth and vaginal birth after cesarean, and lower neonatal death.
Midwives are known to decrease the number of epidurals. Lower C-section rates, include lower episiotomy rates, include fewer interventions such as artificially rupturing membranes or putting internal monitors on the patient. There are so many benefits that a patient derives from midwifery care.
Despite the clear benefits, why are so few nurse midwives practicing in California? Nurse midwives are prevented from opening practices, obtaining hospital privileges, even treating critical issues like postpartum depression and substance use disorder due to outdated laws requiring physician supervision.
Unfortunately, in California, we're very limited by our ability to have private practice. Physicians, some of them, their hands are also tied because of medical legal reasons, and their malpractice carriers won't allow them to cover as a supervising physician for somebody who's working outside of the hospital.
Physician supervision is not defined in statute. Supervision does not require the physician to ever be present, nor examine the patient, review their charts, or oversee the midwife's care. The supervision requirement does create a hierarchy where physicians have the power to refuse permission to practice and restricts midwives from providing care. It centralizes nurse midwives in areas of the state where physicians already practice, while restricting practice where midwives are needed the most. In short, physician supervision does not enhance safety. It's a discriminatory rule that prevents women from accessing care. California is one of only 4 states in the country that still imposes these restrictions. With maternal health care shortages at a critical high, we need nurse midwives in California, now more than ever.
I have worked in states where midwifery was not supervised, but was independent practice. And I really see no difference in the quality of midwifery practice in places where supervisory limitations don't exist.
Midwives, they really are very complementary to physicians, and it really can free up physicians to have a division of labor where they do things that they are specially trained for and allow midwives to provide what is often superior care to women for natural birth.
There's a current crisis in OBGYN in America today. There are not enough OBGYN doctors to provide the care that's necessary for the women who need that care.
We have 9 counties where there are no obstetric providers, and because physician supervision is required in order for midwives to practice, midwives can't go there either. And if the doctors don't want to go and the midwives aren't allowed to go, who's going to care for those women?
Midwives, by virtue of their ability to provide care for normal pregnancies, and also they can do normal gynecology, can certainly help that particular crisis. And I think they're part of the solution for the decreasing number of OBGYN providers.
We all know the statistics are horrid. African American women and babies are at risk for 3 to 5 to even higher times more morbidity and mortality than white women, regardless of class and economic status, education, any of the other things. We've done so many studies around this, and basically the studies have shown that it's racism.
Racism and toxic stress have huge implications on women's health care when they impact your likelihood of having a premature baby, your likelihood of developing preeclampsia during your pregnancy. The kind of care that you get, the amount of stress you endure during your pregnancy, as well as in everyday life, can have a huge impact on your outcomes.
Midwives are at the forefront of the work around inequities in our healthcare system, both racial inequities, socioeconomic inequities, sexual identification equities. All across the board, I see midwives at the forefront of this battle. I see midwives as the leading edge in dealing with inequities in healthcare.
Cnma also co-sponsored a bill to bring implicit bias training to all people who interact with people during pregnancy.
One of the things I really wish we had, and I know that we need to work harder to achieve, is to bring in more midwives of color, more women of color into midwifery. We especially need Black women to enter this profession. Black women already know the solution. They just need to be at the table and in the driver's seat to steer us and direct us to a better destination.
Midwives bring down overall health costs in a number of ways, one of which is decreasing the number of interventions around birth, decreasing the C-section rate and the cost that's inherent in that. They also, by providing preventive health care, decrease the number of hospitalizations and procedures that need to be done.
Women deserve evidence-based, high-quality, women-centered care, meaning midwifery care, in every part of this state.
We know our scope of practice, we know when we need to co-manage, and we know when we need to transfer care. Other than that, we're fully capable of operating independently, and we have great outcomes.
Midwifery is a very important element of providing care for women. Midwifery is essential to protecting normal birth, and their scope of practice is clearly delineated, and I don't see that there needs to be physician supervision.
All right, so now we're going to move on to SB 1237, the actual bill itself and the language therein. This part of the presentation may be a little bit more mundane, but very important and also very exciting, because truly it has the ability to transform midwifery care in California going forward. So SB 1237 was named the Justice and Equity in Maternity Care Act. This was authored by Senator Dodd, who brought Assemblymember Autumn Burke on very early in the process because she was the author of our prior 3 bills. And then Senator Mitchell came on later on in the process, as well as Evan Lowe when this bill went through his committee. So SB 1237 is written in different sections, and I'm going to run through each section and go through the language, which is very important. The first section is the findings and declarations section, and this frames the bill in terms of disparities in outcomes and access to care, and speaks to the many maternity care deserts that Paris has alluded to. This acknowledges the structural, systemic, and interpersonal racism that exists and the resulting racial disparities in healthcare, and that these are complex problems that need to be addressed. This section highlights midwifery as an innovative strategy for disparity reduction, and it notes that the expansion of access to midwives and team-based care holds great promise as one of the strategies for reversing these trends. Section 2 refers to Stark Law. This is already in statute for physicians, and this language was taken directly from physician statute. It now applies to certified nurse midwives, and this refers to financial interest, so that now it is unlawful for a certified nurse midwife to refer a person for lab, diagnostic imaging, physical therapy, or other diagnostic or treatment services if that certified nurse midwife or their immediate family member has a financial interest with the person or in the entity that receives that referral. Section 3 establishes the Nurse Midwifery Advisory Committee. This committee is already in existence, but going forward, the NMAC will have more strength and will be broader in what it can accomplish. The Nurse Midwifery Advisory Committee shall advise the Board of Registered Nursing on all matters related to midwifery practice, education, appropriate standard of care, and other matters as specified by the board. The NMAC shall provide recommendations or guidance on care when the board is considering disciplinary action against a certified nurse midwife. And the bill now increases the number of committee members to 7. So we have 4 certified nurse midwives, 2 qualified physicians, and 1 public member. Right now, the Board of Registered Nursing is recruiting people for this committee. Section 4 is a very substantial section of the bill that really defines what our scope of practice is. This creates our low risk scope and establishes that there are no legal requirements for written or signed protocols or standardized procedures when we are working within this scope. There is an exception to this with furnishing controlled substances, and we'll get to that later in the presentation. This also preserves the ability for us to co-manage and attend the births of more complicated patients in a collaborative model with physicians. This is what we would call team-based care. So specifically, the nurse midwife independent scope of practice includes low risk pregnancy and childbirth, including prenatal, intrapartum, and postpartum care, immediate care of the newborn, interconception and care and family planning care, such as basic gynecologic care for common conditions, such as urinary tract infections, preventive care, such as pap smears, sexually transmitted disease management, and really all contraceptive methods except for surgical interventions. And all of this care must be consistent with the core competencies for the basic midwifery practice adopted by the American College of Nurse Midwives and approved by the board. These core competencies are continually updated, and they were last updated in March of 2020, and they offer somewhat of a broader scope than they did in the past. So specifically, a low-risk pregnancy means a pregnancy in which all of the following conditions are met. It's a single fetus in a cephalic presentation at the onset of labor. The gestational age is greater than or equal to 37 and 0 weeks and less than or equal to 42 and 0 weeks at the time of delivery. The labor is spontaneous or induced, and this is very important. There is no pre-existing disease or condition, whether arising out of the pregnancy or otherwise, that adversely affects the pregnancy, and that the certified nurse midwife is not qualified to independently address. And again, this refers back to the ACNM core competencies. Importantly, subsection B preserves our ability to co-manage and attend the births of patients who are not included in that independent scope of service within a physician CNM collaborative practice model. So we can still co-manage higher risk or moderate risk patients. However, in this patient demographic, we do need to have mutually agreed upon policies and protocols that delineate the parameters for consultation, collaboration, referral, and transfer. Again, this is actually the language in the bill. These mutually agreed upon policies and protocols must be signed by both the certified nurse midwife and a physician. These are not collaborative practice agreements, which can be very restrictive, yet they are written and signed clinical practice guidelines to guide co-management of more complex patients. And this is a guideline put out by ACNM as well. One important note on this slide is that these need to be signed by a physician, but not all physicians whom you work with. So perhaps the chair of the department or some other designee, but all the certified nurse midwives who are practicing must sign these policies and protocols. In this section, the intrapartum and birth care of patients with a previous cesarean birth or myometrial surgery requires team-based care, and thus those mutually agreed upon policies and protocols. A vaginal birth after cesarean can, however, occur in any birth setting as long as you do have those policies and protocols in place. The prenatal care of patients who intend to have a trial of labor after cesarean, however, is considered part of that independent and low risk scope. So we have the ability to counsel patients and help them in their decision making about having a vaginal birth after cesarean. Section 5 is all about furnishing medications. Within this law, we will be able to furnish medications without standardized procedures when we are practicing within that independent scope and that low risk scope. This allows for the furnishing of medications for conditions that are not in that independent scope as well, but in that case, we need those standardized procedures. This clarifies that standardized procedures are always necessary for all narcotic medications, and it is no longer required that we had a 4-to-1 ratio of physicians to nurse midwives for the furnishing of medications because SB 1237 removed that requirement for physician supervision. This is a graph that just shows very nicely what you need a standardized procedure for and what you do not need a standardized procedure for. Standardized procedures are needed for medications that don't fall within our independent scope and for furnishing narcotics. Standardized procedures are not needed for medications within that independent scope. And one other thing to note is that they are also not needed anymore for episiotomy or laceration repair. Section 5 also allows certified nurse midwives to directly procure supplies and devices, obtain and administer diagnostic tests, directly obtain and administer non-scheduled drugs, order lab and diagnostic tests consistent with the provision of services that fall within that independent scope, and receive reports that are necessary for the practice of nurse midwifery. This is really important for the community-based certified nurse midwives, and we are working with the BRN and other agencies to update their websites and documentation to reflect this. Section 6 specifically addresses episiotomy and laceration repair. These can now be done in all settings, including the home. This is a change from prior law, and we can do these procedures without standardized procedures. In Section 7, it mandates some disclosures for births that occur in the community setting. There are a number of different things that need to be disclosed, such as whether you have malpractice insurance, what your transfer plan is, whether you're, or the fact that you are not supervised and that you have independent practice. We hope to create a template for you to be able to adopt in your practices. And again, this only applies to certified nurse midwives who are not practicing in the hospital setting. All right. Section 8 of the bill is about data collection for out-of-hospital or community birth. This will rely on the birth certificates to collect data on patients who birth in the community setting, and it will create an annual report of their outcomes. This is very important because currently data is collected on licensed midwives and all certified nurse midwife births in the hospital setting, but not in the community setting. This new data collection and reporting will occur also on hospital transfers. The reason for the transfer, other conditions of the patient and the newborn, and it will link the patient discharge data with the birth certificate data for these transfer cases. So this will provide important information on the outcomes. This will not go into effect until a budget appropriation is made by the legislature, and we are working on this right now to try to get this into this legislative session. The earliest that this will go into effect is the data collection will begin in 2024, and the first report will be out in 2025. And one important thing to note is that hospitals are mandated to collect transfer information on a specific form for licensed midwives. This is reported to the Medical Board of California. This has been collected on certified nurse midwife transfers in the past, but this is not required and it should not be done. We are regulated by the Board of Registered Nursing, so it's a completely separate board, and there's no requirement to collect transfer data in this manner. So there are many things that you can do, hospitals can do to be in compliance with the bill. One thing about SB 1237 is we crafted the language so that it creates a team-based model of care, which is already in effect in many hospital settings. So hopefully you will not need to recreate the wheel going forward. Many Kaisers, UCs, and Sutter facilities already have a team-based model of care. Hopefully you will only have to make minor adjustments to your departmental documents in that case. The standardized procedures will be required for furnishing of medications not in that independent scope, furnishing of any narcotic for any condition. When caring for patients with a medical diagnosis that are not in our scope of practice, and anytime there is severing or penetrating of tissues, such as when certified nurse midwives are first assisting, but this will not apply for episiotomy or repair of first or second degree lacerations. We recommend highly that you become familiar with the core competencies for basic midwifery practice put out by the American College of Nurse Midwives. This applies to certified nurse midwives as well as hospital systems and health settings. At a minimum, you need written policies and protocols signed by all the certified nurse midwives and a physician that delineate, again, the parameters of consultation, collaboration, and referral for the care of patients that fall outside of the independent certified nurse midwife scope of practice. CNM care of patients attempting trial of labor after cesarean must be included in those signed policies and protocols if you are offering VBAC at your facility. Certified nurse midwives must chart all consultations, referrals, and transfers in the patient record, and hopefully that is already happening. And then also, certified nurse midwives must refer all emergencies to a physician immediately, but may provide emergency care until a physician arrives. So there are many steps that hospitals can take to improve integration of care. Removing supervision language that is currently in place, such as the CNM will be supervised by a physician, and you can replace this with team-based collaborative language. You can certainly decrease the duplication of tasks. Physicians no longer will need to provide co-signatures on orders, H&Ps, discharge summaries, delivery notes. This is really a relic of supervision, and different hospitals had different systems in place to try to be in compliance with supervision. That is no longer necessary. If you currently don't have certified nurse midwives at your facility, you can start planning on how to extend privileges to certified nurse midwives. There are many references in the end of our presentation that can help you try to make that happen. We would encourage you to consider privileging community birth midwives specifically so that when they transfer their patients to the hospital, their care will be streamlined and uninterrupted, and we can offer the best care possible to those birthing individuals. In your facilities, we encourage you to educate your executives, your staff, your nurses, your physicians about the advantages of this team-based model of care between physicians and certified nurse midwives. And we want to encourage everyone to do everything they can to create a culture of care that is patient-centered, where diverse care teams are the best suited to serve diverse patient needs, and we can meet the needs of the patients we care for in the best manner possible. Thank you very much.
Integrating nurse midwives creates so many opportunities for hospitals and health systems with increased access to care, especially in maternity care deserts and critical access hospitals. And we'll explore a few of these things, starting on the next slide. First of all, utilizing midwives is a very easy way to simply increase access to maternity care. This slide is from the Listening to Mothers survey in California, which was conducted by the National Partnership for Women and Families and presented by the California Healthcare Foundation. As you can see, birthing people in California are ready to see midwifery care scale up. This poses a powerful strategy to increase access to care, especially in maternity care deserts and critical access hospitals. Importantly, this is not just a matter of more care, but as you'll see on the next slide, it's high quality care. Midwives are known for being kind and gentle with patients. And according to that same Listening to Mothers in California survey, this is something more women want. Experience of harsh treatment and rough handling is unfortunately far too common. But we also know that hospitals that offer midwifery services see higher patient satisfaction rates and better reports of care, even among those patients whose care is primarily provided by physicians. This is an example of how midwives impact and shape culture within hospitals and practices. Another opportunity midwives present is shown on the next slide: greater access to TOLAC and VBAC. When nurse midwives are part of the staff, VBAC rates, as well as overall vaginal birth rates, go up. Midwives are experts in normal vaginal births. And as you can see on the next slide, that expertise plays out in the statistics. You can see here that overall nurse midwives patients have the lowest C-section rates. Unfortunately, you can also see that overall C-section rates reflect the healthcare disparities we see across racial boundaries nationally. And as you'll see on the next slide, this is just one of the reasons that the March of Dimes has called on American health systems to scale up access to midwifery care and to integrate nurse midwives into hospitals. The March of Dimes position statement, Midwifery Care and Birth Outcomes in the United States, says more of the same. Essentially, women with low to moderate risk pregnancies who receive midwifery care or who have access to collaborative care that integrates midwives are more likely to experience a low intervention, spontaneous vaginal birth, more likely to be satisfied with their care, and less likely to have that first cesarean delivery, thereby improving outcomes for all of their subsequent births. They go on to discuss how integrating midwives can help improve access to maternity care providers in under-resourced areas, reduce interventions that contribute to the risk of maternal mortality and morbidity in initial and subsequent pregnancies, lower costs, and potentially improve the health of mothers and babies. With increased patient satisfaction, hospitals have the opportunity to attract more patients, not only for maternity care and childbirth, but across the patient's and her family's lifetimes. Satisfied women bring their families back to their hospital for future care. And moving on, you'll see that we also save hospitals money. Since 1996, the cost of childbirth has tripled. A large part of that increase stems from steeply rising cesarean rates. Cesarean sections cost 50% more than vaginal births for both Medicaid and private health insurance. Midwifery care saves money by using fewer C-sections, epidurals, and episiotomies while avoiding complications. This translates into future cost savings through fewer repeat C-sections, in addition to long-term cost savings via increased breastfeeding rates. This slide presents data from a policy brief published by the University of Minnesota's School of Public Health in 2019, recognizing that payments and costs differ between Medicaid and private health insurance, with private plans paying approximately 50% more than Medicaid for childbirth-related care. They calculated potential cost savings separately from Medicaid and private health insurance. In addition to showing total potential cost savings for the US as a whole, increasing the percentage of pregnancies with midwife-led care from 8.9 to 15% would result in over $1 billion in cost savings by 2023. By 2027, if midwives were leading care for 20% of all births, savings would reach $4 billion. About 3/4 of these cost savings are attributable to lower costs for births covered by private insurance, while 1/4 of the cost savings would be from Medicaid covered births. Specifically, by 2027, cost savings associated with this modest shift toward midwife-led care would reach $2.82 billion for private health plans and $1.13 billion for Medicaid programs. It's important to note, though, as illustrated on the next slide, that this does not mean that midwives work in a vacuum. As you probably know, ACOG has an excellent paper on team-based care. Team-based care is the provision of health insurance by at least 2 healthcare providers who work collaboratively with patients and their families to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated, high-quality care. A team-based model of care is one that strives to meet patient needs and preferences by actively engaging patients as full participants in their care, while encouraging all healthcare providers to function to the full extent of their education, certification, and experience. Patients and families are active and central to and actively engaged as members of team-based care. The team has a shared vision. Role clarity is essential to optimal team building and team functioning. All team members are accountable for their own practice and to the team. Effective communication is key to quality teams. Team leadership is situational and dynamic. Women have diverse needs, and those needs are met by diverse providers with diverse specialties. ACNM and ACOG's Statement of Joint Practice Relations states, ACOG and ACNM believe healthcare is most effective when it occurs in a system that facilitates communication across settings and among clinicians. OBGYNs and CNMs and CMs are experts in their respective fields of practice and are educated, trained, and licensed independent clinicians who collaborate depending on the needs of their patients. These clinicians practice to the full extent of their education, training, experience, and licensure, and support team-based care. ACNM goes on to say that collaboration is the process whereby healthcare professionals jointly manage care. The goal of collaboration is to share authority while providing quality care within each individual's professional scope of practice. Successful collaboration is a way of thinking and relating that requires knowledge, open communication, mutual respect, a commitment to providing quality care, trust, and the ability to share responsibility. While the terms collaboration and team-based care are often used interchangeably, it's important to note that collaboration is necessary for optimal team-based care, but team-based care requires more than just collaboration between providers. ACOG prefers to refer to team-based care instead of collaboration because in some practices, collaboration erroneously refers to a supervisory relationship. For example, an OBGYN supervising a nurse midwife. Team-based care is preferred because it is more comprehensive definition of patient-centered, high-quality, high-value care. And as you'll see on the next slide, this model leads to optimal outcomes. This slide is from Every Mother Counts, Maximizing Midwifery to Achieve High-Value Care project. It addresses the improved outcomes for low-risk women who receive midwifery care. Again, this speaks to the importance of team-based care, where midwives and obstetricians are working at the top of their practice and where women receive an appropriate level of care. When low-risk women receive midwifery care, We see fewer C-sections and episiotomies, increased VBAC and breastfeeding, and all of this without compromising patient safety. And this frees up our physician colleagues to provide exceptional and focused care to high-risk patients. While most CNM-attended births do happen in the hospital setting, it is important to acknowledge that a small percentage of births will be planned and intended to occur in the out-of-hospital setting. This brings us to the importance of creating smooth transitions. Further integration of midwifery and having midwives in your institution creates an opportunity for smooth transition when patients from the out-of-hospital setting happen and can happen from midwife to midwife, can improve the patient's experience. And most of these transfers are for Pitocin and pain relief. If an out-of-hospital midwife has privileges, there might be less incentive for them to stay home when the patient knows she can continue care with her midwife. It's potentially, in some circumstances, better for the patient and better for the hospital's bottom line. Allowing privileging of community-based nurse midwives allows for early and appropriate transfer to a higher level of care when needed, provides for the highest quality and safest care, and builds trust within the community by providing women with more options and the care that they desire. This means offering respectful care no matter the patient's philosophy or choice of birth setting. Countries in which care is more integrated between the community and the hospital have better outcomes and higher patient satisfaction. And as you'll see on the next slide, countries with the very best outcomes have a ratio of OBGYNs to nurse midwives that is really quite different from ours. Again, Senate Bill 1237 offers an opportunity to change that in this state. Now, I'm sure you're all wondering what you can do to get started. So we've provided lots of resources. The California Nurse Midwives Association, ACOG, the Pacific Business Group on Health, and so many others. We have pages and pages of references on the final slide. Now, I'm not going to take up any of your time by reading those to you, but those resources will all be made available as a PDF available on our website. If you have any questions, I would urge you to check out our website, cnma.org, but you can also email us directly. You can email me, Paris, and my email address is listed there, or Holly Smith, again, she's our health policy chair, or Kathleen Belzer. Meanwhile, we look forward to supporting you in the work that you do to integrate nurse midwifery care into your hospital setting. Thanks.